Welcome to this presentation of language barriers and medical care. A quick note before we start. This presentation is intended for medical students, especially students in clinical communications, medical professionals that need to complete continued professional development credits, people who have heard about this issue, who are passionate about it, who have never heard about it, and most importantly, native English speakers and non-native English speakers. That means that these slides are text dense. I'm going to try to move as quickly through this presentation as possible, which means if you're viewing this, it's best done on a computer in full screen mode. The PDF is also available, but if you want to pause and look at the text and read it fully, definitely do that. I'm going to try to move as quickly as possible. So, with that said, let's go. So, before we start, it's in our interest to ask how many countries are in the world and how many languages are spoken. Go ahead, take a guess. The world has 195 countries and there are 7,000 languages spoken in the world. Here's an infographic of the world's top 23 languages with the number of native speakers. I would ask, which of these languages do you see typically translated, and why do you think this is the case? I would also note that some of these languages are more subdivided than others. I can see, for example, Chinese and Arabic. Yeah, so that's a question for another time, but worth noting anyway. Another question worth asking before I start is, what is Twig? Who am I? Who are we? So Twig, the Medical Translation Database, is a charity registered in the United Kingdom. We are a free wiki of medical questions translated by medical professionals all over the world. Our goal is to create a wiki of medical questions in as many of the world's languages so that patients can receive access and information in the language that is closest to them. Yeah, in the language that is closest to them. We do always need volunteers at Twig. Just a quick plug. The first question to ask, are you bilingual or monolingual? If you are a bilingual medical professional, all professions, we would like you to translate. That would mean providing written translation and audio translation. We do provide video translation for the deaf and hard of hearing communities. What's in it for you? You get a lasting way to provide translations. You get to be creative. You get to broaden research. You get to share. Translation is enjoyable. It's meaningful. And you can also meet other bilingual doctors and or medical students. So there is a community aspect to it. If you are monolingual, we would like to hear what issues you've had with language barriers on behalf of your patients, because we often don't hear from patients. Suggest use cases for us, talk about frustrations you have, steer us in the project in the way that is most helpful for your patients in your practices. And this is also rewarding, enjoyable, and meaningful. So we definitely need everyone. Yeah. So having said that, let's move on. If you want to know about me, my name is Bradley. I taught medical English at a university in Rome for a long time, and I'm interested in the legal and clinical ramifications of language barriers in medical practice. Yeah. Okay. So when we say use cases, we need people to tell us about use cases. This is what I'm talking about. Yeah. So if you're bilingual and you want to help volunteer, or you're monolingual, we're interested in the challenges that patients face when they have language barriers in clinical care. That could be where they're from, where they are currently, their life experience, and their patient experience that is common to your location. So that's that. Twig does have a research aim in addition to a wiki aim, just, simply providing as many translations as possible. So we need volunteers to help us with language translation and use cases on behalf of patients long term. So what makes Twig unique? Volunteers can select from over 7,000 languages. Volunteers identify where their language is spoken on a map. Yeah, so this will allow Twig to match patients with languages depending on geography, depending on where they're from. Twig volunteers verify translations within the system, each other's translation. This ensures the appropriateness of translations for vulnerable patients. Yeah. Yep. And then, as I said earlier, we also are very interested in deaf and HOH communities, and we currently offer 200 different signed languages. Yeah. So, some medical facilities can pay for live translation services, but even communities with resources can normally afford to provide about 50 to 150 languages. In 2017, the cost of translators to the British NHS was £100 million. Computer translation systems offer a similar range of languages. For example, Google Translate offers about 100 languages. Yeah. Fine. So I've talked about the number of languages in the world. What we aim to do at Twig, we are biased in favor of really good medical translation on behalf of patients. Now it's time to just get into some of the issues that surround medical translation. So when people think of translation, they often think of migration. So let's cover that right off. When we talk about migration, we are talking about translation needs current versus future. While it is true that patients who need medical translation are often immigrants or migrants, this is not always the case. We'll talk about that later. Regarding immigration and migration, this presentation covers the current situation as it is on the ground. It is important to remember that migration may change drastically with little warning. Climate change and political factors may or may not accelerate this process. Let's look at some maps. It is unclear how many people will migrate due to climate or political change in the future, and how many will simply adapt in place, so they will become internal migrants as their environment changes. The following maps indicate where crunch areas might be in the world. Let's go. It is worth considering what populations might need medical translation in future and what languages they'd speak. So whatever you answered in previous slides about the languages you typically see translated today, let's look at some maps about what also might need to be translated in future. Here we go. The IDMC monitors internally displaced people, IDPs. So we can see that on this map. And so does the ICRC. If you'd like to check them out, there are some links there for you. And here on this map at the left, we're looking at climate change migration zones. Here's a map by the IDMC of new displacements by conflict and disasters. And as I am speaking to you, the map that we are looking at is already dated because this map changes constantly. Yeah. But here are some new displacements by conflict and disasters as of 2019. International migration figures can be found at the IOM. This includes the yearly World Migration Report. The IOM also has a map. They have interactive maps, lots and lots of them. This map shows the share of international migrants within each country. Yeah. You can also monitor human trafficking. It's important to think about human trafficking on the CTDC site, including trafficking routes, and UK migration at the Migration Observatory, which is at the University of Oxford. It is important to remember that people often grossly overestimate the number of immigrants to their countries. Yes. So, people often think that their countries are there's just tons and tons of immigrants and migrants. But if you look at the perception versus the reality, here are some charts. So I encourage you to look at your own country, the number of perceived migrants that you think you have, and the actual number of migrants in your country. Okay. Here's some additional reading if you're interested in immigration and migration. Okay, here we have some tips for dealing with migrant patients, immigrant patients, migrant patients. These are tips from Twig Translators. They are not exhaustive, so check for best practice in your area and check out the laws in your facility. However, these are the typical problems, yeah. Firstly is costs. Patients may not understand the costs involved with treatment. Explain how this works in your area because they also may put off care, yeah. Medication. Patients often misunderstand the medication they're given, where to get it, how much it will cost, whether it needs to be refilled, how often to take it, how to take it, this is big, and side effects. They often don't understand whether they are eligible for a translator or interpreter provided by the medical facility. Be clear on whether they'll have an ongoing relationship with an interpreter or if that person will be different every time. If you know of a charity, religious order, cultural mediator that deals with a certain patient's language or culture, pass that information on to them. Patient care with migrants often breaks down in the scheduling of follow-up appointments and referrals to other professionals. So make really sure before the patient gets out of your office that they're aware of their follow-up scheduling, locations and dates. Explain exactly what is involved in processes that might be invasive. This includes imaging, blood draws, reproductive health checkups for sure. Explain what a chaperone is if necessary, and offer one if it's available in your area. It is common for doctors to give patients websites that they can check in English, regarding their condition. Some migrants might have the infrastructure for that. They might have a great computer and Wi-Fi access. Some might not. Some migrants might be tech savvy. Some might not. If you're giving them materials in English, of course, the language is still a problem, so you're just passing that problem on to them, which might be appropriate, it might not be. Always plan double the consult time for a patient who has a language barrier. This includes for consults with translators, don't always assume a clinical history that's similar to a local patient. Also, safeguarding. Some people might call this mandated reporting, right? Or duty of care. If your patient has brought their own translator, consider whether this person could be an abuser or a human trafficker. This person might also just simply be not appropriate as a medical translator, without any malevolence, they just might not be appropriate. But quite often, we could talk about carer abuse, modern slavery, human trafficking. Think about the person that your patient has brought as a translator. So also don't assume that a patient will be necessarily as interactive as a local patient. Yep. All right, so I can see my screen has told me it's time to move on. Here we go. The question next is how many patients currently face language barriers in medical settings? Or, put from a provider's perspective, what percentage of my patients will face language barriers in medical care? It's impossible to give a universal answer to this question, but the numbers are often higher in areas that I've listed out here in bullets. Twig would like to further research what percentage of a medical provider's patients require a translator worldwide. Our test users currently report that between 10 and 30% of their patients would ideally require a translator. 10 to 30%. When you look up the facts for your own area in a search, you might find these kinds of statistics. I've done statistics for the UK. You might find it that the city of Croydon near London currently offers translation in 50 languages. You might find that 4.2 million people in England and Wales speak in a main language other than English or Welsh. That's 1 in 13 people. And that in Leicester, up to 9% of the population doesn't speak English well or at all. These are the kinds of statements that you read in policy papers, yeah? And readers might come away thinking, wow, 9% of people, that's a lot, that's a real problem, right? Or that language provision in 50 languages, that's quite a lot, like job done. This kind of data is a starting point, but the real picture can be more complicated. To make a long story short, a lot of this information comes from census data, which not only is done once every 10 years, it doesn't include undocumented residents, it may undercount documented residents, it may not account for a sharp uptick in migration, it may not count people that people are avoiding seeking medical care if the information has come from a medical provider themselves, etc., etc. I've put out here some things that are problematic about these kinds of policy papers. Yeah. Your homework assignment is to learn more about the demographics of the community where you practice, even if you were raised there. So, imagine that you are a nurse practicing in Croydon. You might find the following data in an internet search in the PDF slides 34 and 35. So, the idea is to then interpret this in terms of language provision for patients. Here we have some census data, some maps. Office of National Statistics, always a favorite. So the point I'm trying to make here is that you may have seen, and I encourage you to pause and go back if you need to the previous images. What you will find quite often in a search are results that involve nationality, ethnicity, documentation status, language, and religion. Do not conflate them. In the last 2 slides, we learned that 30% of Croydon residents were not born in Britain, that 17% do not have British citizenship, that people who live in Croydon were born in different countries. We learned the languages that residents in Croydon speak, that residents in Croydon belong to different ethnic groups, that 100 languages are spoken in Croydon, and that a large number of unaccompanied minor asylum seekers live in Croydon. Some of these are relevant to language provision in medical settings, some are not. That brings us to language, nationality, ethnicity, and citizenship. This chapter is the result of many, many conversations with physicians and people in clinical communications, students, difficult, honest discussions. So important, difficult, but important, and let's move on. Note that it never takes a long time before the discussion about medical translation starts including citizenship and social identity. This is understandable because medical translation involves resources, time expenditure on the part of staff, and often funding. Someone has to decide where resources are allocated, and rightly so. Let's examine some words that commonly come up in these scenarios. So, let's remind ourselves about the words that we're using. Population is a geographic and demographic concept. People is a historic and social concept. Citizen and citizenship is a legal concept. Nation is an ideological and political concept. State is a legal and political concept, capital S, state. Ethnicity is a social and biological concept. So this slide refers to our Croydon exercise. I'm not going to read it out. You're welcome to look at it if you'd like. So lots of the information that we saw in the Croydon exercise comes from the census, and censuses are produced by governments and they have their own aims. But we tend to take these on in public policy, health policy, and the result might be something like this. One can imagine a hypothetical Dr. Chris on the US-Mexico border saying, "I don't want to pay for non-citizens." And we might take non-citizens to mean people with the legal status of having citizenship. However, 3 US citizens might present at Chris's clinic: Joe, whose native language is Spanish but has naturalized to the US, Jane, a speaker of American Sign Language, and Bob, a Native American. And Chris might say, no, American people speak English. So for Chris, you need to be legally American, but also socially American. And for Chris, this means speaking English. Of course, this could be a doctor anywhere, or a nurse, or medical professional anywhere in the world, really. These conversations come up everywhere. But in our hypothetical example, it's important to remember that for Chris, the words in the previous slide, 2 slides ago, might be interchangeable. So Chris might fall cleanly into the default, whatever the defaults are of his given community. So for Chris, their nationality and citizenship, being a member of the American people or of a certain geographic population, they might fall straight into the default categories. And here we're talking about identity. This, of course, becomes more complicated if we add in other factors related to identity, like socioeconomic status, religion, or gender. But for Jane, Joe, and Bob, these concepts might not be interchangeable or default. So it's inevitable that discussions of medical translation should discuss allocation of resources. Yeah. These discussions often lean towards citizenship or legal status, and perhaps of patients speaking the local language as a matter of social conformity, identity, becoming part of a people. And it's desirable that we realize when we're doing this. So when we're having this discussion, which is a discussion to have, we are not talking about other things, right? So we're missing out on other discussions that we might have. For example, the patient experience, health, clinical communications, culture, access to care, best practice, medical malpractice, medical ethics, training on how to use translation, best uses of available resources, quality of translation, and the gaps between expectations and daily realities. These are other conversations we could be having. Yeah. So it is up to you to rank these concepts If you're prioritizing, if you're thinking about this discussion, what do you think the most important concepts are for you, ranked? So this brings us to homework assignment 2. Think about your own identity using the previous slides. Are your identity components the default in your community? Are some of the components that make up your identity more important than others? Examples: gender over religion, nationality over citizenship. If you know a person who is bilingual, ask them the same. Ask this person to imagine they've got a sudden chest pain. They hurry to hospital and there is a nurse or doctor available in every language they speak. Which language would they prefer to be treated in? If you're bilingual, ask yourself, which language would you prefer to be treated in? So, takeaways from the Croydon exercise are that 15% of the residents of Croydon speak languages other than English. Croydon has 378 residents. And so 15% of these will be non-English speakers. This leads us to the conclusion that we have 54,507 people in Croydon that do not speak English as a first language. We know that the Croydon NHS offers medical translation in 50 languages, but that 100 languages are spoken in Croydon. This information came from the previous slides. So, the question that we ask ourselves at Twig is, what percentage of the 54,000 or more residents speak languages other than the 50 offered by Croydon NHS, the Croydon Hospital, yeah? So, this is just a note about censuses and what they ask and how governments come up with these numbers, because quite often the numbers that you will find are either from a government, from a hospital, or from a language provider. If you're interested in your own census, you can go to this link from the United Nations to see what questions your country asks. The British NHS collect data on ethnicity. Their reasoning is as follows. You can pause this if you'd like and read it. So, this is the situation multiplied in communities around the world. We're lucky in this situation because we have a lot of information about Croydon, and the United Kingdom produces a lot of information. You may find less in your situation. Getting to the case study, now is a good time to take a break and think about what your feelings are about medical translation. Some of the responses I get when I give in-person talks are: A, this reminds me of my grandparents. B, this is a logistical nightmare. We only have 15 minutes for each patient at our clinic. C, why do I have to provide language services for these people? I didn't go to medical school for this. Why can't they just learn English? D, I didn't speak English when I moved to this country as a child. Then I went to nursing school. I really see myself in these patients. I know them from my community. E, I'm not a native English speaker, but I'm a doctor or nurse who did my medical training in English. Of course patients have issues. English is so weird. No, really. Think about which opinions on the previous page are most you at the moment. It's homework assignment 3. Are you a C? That's okay. This topic isn't everyone's cup of tea. By the way, if you are a bilingual medical professional and answered A, D, or E, we'd really like you to consider joining the volunteer translator community at twigcare.org. If you're not bilingual but are interested in these issues, we'd like to hear from you, especially about common issues with patients. Here's the rest of homework assignment 3. Assess your gut feeling about medical translation. We've already done that. Did you receive any training on how to use translators? This could be either in clinical communications courses with SPs, simulated patients, or otherwise. Have you had any experience or training with deaf or hard of hearing patients? Do you know if any languages are banned in your country? Do you know of any indigenous groups that live in your area? Do you know that language barriers can lead to cases of medical malpractice? Getting to the case study, now is a good time to take a break and think about what your feelings are about medical translation. Some of the responses I get when I give in-person talks are: A, this reminds me of my grandparents. B, this is a logistical nightmare. We only have 15 minutes for each patient at our clinic. C, why do I have to provide language services for these people? I didn't go to medical school for this. Why can't they just learn English? D, I didn't speak English when I moved to this country as a child. Then I went to nursing school. I really see myself in these patients. I know them from my community. E, I'm not a native English speaker, but I'm a doctor or nurse who did my medical training in English. Of course patients have issues. English is so weird. No, really. Think about which opinions on the previous page are most you at the moment. It's homework assignment 3. Are you a C? That's okay. This topic isn't everyone's cup of tea. By the way, if you are a bilingual medical professional and answered A, D, or E, we'd really like you to consider joining the volunteer translator community at twigcare.org. If you're not bilingual but are interested in these issues, we'd like to hear from you, especially about common issues with patients. Here's the rest of homework assignment 3. Assess your gut feeling about medical translation. We've already done that. Did you receive any training on how to use translators? This could be either in clinical communications courses with SPs, simulated patients, or otherwise. Have you had any experience or training with deaf or hard of hearing patients? Do you know if any languages are banned in your country? Do you know of any indigenous groups that live in your area? Do you know that language barriers can lead to cases of medical malpractice? We previously looked at Croydon in the United Kingdom. Now we'll look at California in the United States. The National Health Law Program did the following study regarding the high costs of language barriers in medical malpractice in 2011. The researchers found that in 35 claims, 2.5% of the insurer's total claims, the carrier paid $2.2 million in damages or settlements to patients and $2.7 million in legal fees. Researchers identified 35 closed claims that involved significant language barriers from January 2005 through to May 2009. The insurer operated in 4 American states. Case studies from the report follow. So, I won't read these case studies to you. The following case studies involved some misunderstandings regarding ethnicity, identity, language, and I will ask that you pause and read them yourself. We have also some really serious negative outcomes and fatalities with patients, so it's really important to read these case studies, yeah? Case study 1. We have the Wong case, and I would ask that you pause and read. The Chan case, I would ask that you pause and read. So, I've highlighted these case studies because they involve conflating ethnicity, race, and language, the topic we've previously discussed. The report found that this problem in the United States was more common with Asian patients because many providers tend to aggregate the diverse Asian languages and cultures as just being Asian or Chinese. Providers were confused about the distinctions between Cantonese, Mandarin, other Chinese dialects, or Vietnamese, and the nationalities, races, and cultures from patients from Hong Kong, Taiwan, Vietnam, and Macau. Even if the patient was correctly identified as Chinese, providers failed to consider the possibility of further barriers manifested in different language dialects, Mandarin, Cantonese, or other Chinese dialect. None of the cases noted any provider asking the patient for clarification of their primary language. Note that this is possible physician to patient, patient to physician, or physician to physician, this problem, yeah? However, the study's findings were more broad. I strongly suggest reading the whole report, but here are some of the major takeaways. Number one, the cases resulted in many patients suffering death and irreparable harm. 2 children and 3 adults died. Number two, in 32 of the 35 cases, healthcare providers did not use competent interpreters. Number three, 12 of the claims involve the failure to translate important documents, such as consent forms. Fine. And you can read the rest. Please pause and move on when you're ready. The United States, unlike Britain, does not have a public healthcare system. When medical care goes wrong, patients can take legal action against a hospital or physician's insurance. Because communications between medical staff and patients are private, we rarely get a glimpse as to what happens when things go terribly wrong. From a research standpoint, these data are important and help to build best practice. Twig needs and welcomes any similar data from any other countries and viewpoints. Meantime, if you're a C and medical translation doesn't float your boat, it's important to know that 1. Medical translation can become an issue of medical malpractice. 2. You may have to provide translation by law for some native citizens in your community, Indigenous people and ethnic minorities. 3. You will likely have to provide medical translation to members of the deaf and HOH community. Here's some additional reading if you're interested. So, another thing that I get asked a lot is, do I have to provide a translator to patients? Even physicians don't agree. A nice summary of opinions can be found in this article. To sum it up, one of these physicians believes that you do, especially for older patients that just don't have a lot of contact with English language. And another doctor who says that it's our duty to encourage patients to speak English. You can read these articles here if you'd like to. Feel free to pause and read fully if you're interested. So, if you're interested in the legal issues surrounding having to provide a patient with a translator, here's the legal outline of how that should work under international law. Yeah? Again, you're welcome to pause and read it fully if you're interested. I find this fascinating. So, we're on to case study 2. This woman was present with her elderly mother and a physician during an oncology consult 6 hours ago. The physician used a telephone translation service. She posted her experiences on Reddit, so this would be the patient's daughter, because she didn't know what else to do. Again, feel free to pause here and read it. So here we have a patient and a mom who speak the same language. The patient's daughter speaks English fluently and also her mother's language fluently. And she's commenting on the quality of translation that her mother is receiving. Yep. And here are some comments. So as we will see later, medical translators are often hired by third-party companies who just have translators self-assess their language abilities. Translators are often very poorly paid. We will address this more later. So in this case, the physicians certainly did what was in their power, that is to call a translator, but it is worth considering what improvements could be made in the current system, the satisfaction of the consult both from a patient and a physician's point of view, and what would have happened if the mother had gone to the consult alone and didn't have the daughter, who is her advocate in this situation, who spoke both languages. It's also worth asking, what does the patient want? So, when we ask bilingual patients what language they'd prefer to be treated in, they overwhelmingly respond, "The language my mother or primary carer spoke to me when I was a baby." And this is universally true. When I ask groups of bilingual patients or bilingual doctors, what language would you prefer to be treated in? Just write it down. They'll write it down and I will say, why? And this is the answer is universally the language that my mother or primary carer spoke to me. It's the language that is closest to me, that I understand best. To me, this speaks both to the kind of vulnerability we feel when we're ill, but also the centrality of language in a person's life. So that is to say, the only thing that you've been doing longer than speaking your native language is breathing. It is also worth remembering that we don't poll patient preferences, satisfaction, and feedback for patients who face language barriers, that we often make assumptions about their preferences based on what is easiest for us. An example would be procuring a French translator for a patient from Africa without speaking with them first, or asking them first. We often also have an overly optimistic opinion of how well an interaction went with a patient who needed a translator. So at right, you can see my NHS satisfaction poll, and I get it on my phone with a little pop-up. And I wish we had this kind of thing for patients who face language barriers, because we often don't ask about their preferences, even though patient polling is becoming, and patient satisfaction is becoming, a very common feature of medical care. Yep. So I think it's important that we maintain focus and take some time to look at clinical communications in general. So this is a quote from John Skelton's book. He says, "The first point is that patients have a dangerous habit of taking doctors seriously. This means that what doctors tell patients about themselves, about their conditions, and about their prognoses tends to assume the status of a truth. Doctors, in other words, create ways of seeing for their patients. When they state something is the case, they make it so." After decades of research, here is a summary of what is known in the field and what is less known. Here's what we have researched and, let's say, know about clinical communications. Patient concerns being missed by doctors, especially of a psychological nature. Disagreements between doctors and patients about what the principal problem is. Complaints not completely being dealt with. And doctors using unclear language. Here's what we don't know about clinical communications. Specific elements of communication that maximize patient satisfaction. Collaborative autonomy. Quality of life. Enhancement of coping. Adaptation and recovery. How needs and practice vary in the course of continuing clinical care. Relationship between ethics and communication. Note, language barriers in clinical communications does not fall into either category, of the unknown or of the known, either on its own or in conjunction with another topic. 2. What we know comes principally from Western countries and Western authors. Twig would like to change this through research and its community. If you're bilingual and interested in how any of these issues intersect with language, we would love you to join Twig. And if you're not bilingual but a stakeholder in this field, we'd also love to hear from you and join Twig. When it comes to doctor-patient interactions, we might ask, 1. Does effective clinical communication lead to better patient outcomes? 2. What makes for a good communicator? 3. Can we apply the scientific method to clinical communications so that it can be replicated, studied, and taught? The answers are yes, it's complicated, and it's very, very complicated. It has been noted that the clinical communications field quickly became crowded with researchers making lists as to what qualified as effective communication. Some examples follow. So here we have a checklist from the Maastricht History Taking and Advice checklist. I'm pausing so you can pause. Here's the GMC's Tomorrow Doctor's Guidance. So that's British guidance and guidelines. Here are some other frameworks. There are lots of them as to what makes effective clinical communication. I particularly like the rotor interaction analysis system, yeah. After we look at all of these systems and read through them, it's time to stop and focus. It's hard to determine where communication stops, but it should not be pursued without limit. To say, medical communication is a bit of a rabbit hole, and we should regroup. So, first, let's consider what's going on in the background of a consult. Here's some research by Ong, and these are background variables that seem to influence communicative behaviors, which in turn have an effect on patient outcomes. Here we have these background variables, actual content of communication, and patient outcomes. Yeah. I would add that on the left, not only would it says culture here as a background variable, I would include culture and language. And on the right here where it says patient outcomes, I would include informed consent and medication, as part of maybe compliance. So fine, you're welcome to read this full study at the link provided. So that brings us to homework assignment 4. Think about which of the following are strengths for you. Types of communication skills, content skills, process skills, and perceptual skills. So I would ask you to pause, read through these, and think about what your strengths and weaknesses are in these 3. Which are you? So this is the next. We have, let's say, 3 kinds of medical professionals. A. Patient, I declare that I suffer. Doctor, I commit myself to assisting you. I direct you to take your medication. B. Patient, I declare that I suffer. Doctor, I commit myself to assisting you. We will decide on your medication together. C. Patient, I suffer. Doctor, I reflect. We act. So I would ask, which are you? And do you think that your patients agree or share your modality of thinking? Yeah? Fine. Success in clinical communications might better be measured against your strengths, tools and resources, time, prioritized goals. So this is to say that every situation involving language barriers especially is imperfect and unique, because already a normal consult is imperfect and unique. Translator Procurement. So, this is a vast subject. I will try to get through it as quickly as possible. So, from a translator's point of view, there are 2 schools of thought. One, the translator as machine, and two, the interactive translator role. Yeah. So there are different types of translators in medical translation. I say translators, I also mean interpreters, right? So translators translate written material and interpreters do it verbally, right? I tend to use them interchangeably here. So here we have definitions of interpreter. So a formal interpreter, informal interpreter, ad hoc interpreter, cultural mediator, or advocate. All of these people serve as medical interpreters or translators, practically speaking. You're welcome to pause this and read it fully. Approach models to translation. The no problem approach. It's the migrant's problem to find an interpreter, learn the host country's language. There's no provider knowledge of official policy, issues, rights, or intercultural communications. The linguistic interpreting model. Healthcare professionals are obviously aware of language barriers, but they think the only solution is professional interpreters trained and paid. The power model. Asymmetrical relation between doctor and patient, where the doctor is the leading party, possible feeling of powerlessness on part of patient if doctor loses control of the situation. Lots of side talk between patient and interpreter. Then there's the reality model. This faces reality in order to find flexible solutions. Justice equals neutrality. Every situation is different, and so here's the possibility of training an ad hoc interpreter in a way that becomes professional interpreting. Full disclosure. Twig believes in interactive translation within the reality model. We believe that translators are not computers. They bring both linguistic and cultural experience to their work. We believe that medical professionals currently have to use the tools that they have available in a very imperfect system. So you may be wondering, what is the official policy versus the services that are offered in my country versus the daily practice? And here's the situation in several countries. I ask you to pause it and see the range of what's available in some countries. So it's a good time also to talk about third-party providers, training, and pay. Many governments use third-party companies to provide interpreting services. Some train their employees, some give language tests. Others simply have translators self-assess their skills. The UK seems to pay in a range from £9 per hour to 19, and a typical medical consult is 15 minutes. Savvy physicians often book 30 when they need to use a translator. It is unlikely that a phone interpreter would have calls booked back to back all day, so working hours and salaries will vary. At £19 to £19, at £9 to £19 per hour, this means that a translator would be paid between £2.25 and £4.75 for a 15-minute consult. Note that around the world, family members and ad hoc translators, so some examples are nurse, physician, cleaner, secretary, or other patient, are often used as translators and are unpaid. Medical translation is a largely unpaid or underpaid field. Third-party providers are often winners of bidding in government contracts. So here are some third-party winners of a £100 million UK government contract to provide language services for the NHS from 2016 to 2018. So here are some of the companies that provide language services in the United Kingdom. And here's what some employees on Glassdoor say about working for some of these translation companies. Yeah, here's a Translate Plus review from employees. Here's a review of Language Line, of what it's like to work for Language Line. Yeah. In fact, the one that strikes me here is because language line is international, yeah. It says very low pay. I could not even afford my own apartment in suburban Atlanta working 40 hours a week. Assignment 5. Learn whether translators are paid for or not by your local or national government. 2. If your medical facility uses a translation service, ask how the company assesses language proficiency. Many services only require that the translator self-assess. A proxy for this can be pay. If you find that your medical translators are unpaid or receive low wages, it is possible that they are not qualified to be medical translators. You can find out about translator pay on sites like Indeed and Glassdoor. Search for your translation company by name. Note that many self-taught translators, given experience, can become quite good. However, pay, qualifications, certifications are considerations when knowing that the service you're receiving is good. Your medical facility may use a separate service for deaf or HOH translators, and the same rules apply. This is so important. Medical professionals are the only people who can help raise visibility on this issue on behalf of their patients. And, as per usual, learn more about the demographics of the community where you practice. Case Study 3. So this case study is about a translation company that's gone out of business, patient interactions, employee interactions, and what they eventually said about why they couldn't make a profit and why they folded, which I find quite interesting. So this is Pearl Linguistics. This is the company that we're looking at in our case study. I'll let you pause and read this. I'll let you pause to read this as well. Here, here's an insolvency or bankruptcy declaration. Translation in deaf and HOH communities, so hard of hearing. I often ask groups of medical professionals what they do when they need to find a translator for a patient. I often hear, "I've never needed a translator." This is a canary in a coal mine moment. When someone says this, I always ask how they find translators for deaf patients. As it turns out, many never have. Some say that their patients get along just fine. Except when you ask a deaf person or a member of the deaf and HOH community, you often get a completely different story. Odd, because in many countries, members of these communities have had rights under disability legislation since the 1990s. They're one of the few communities theoretically guaranteed medical translation. The deaf translators I've contacted over the years have reported these experiences. Doctors trying to fake knowing sign language and stop using their translator halfway through the consult. Doctors seem put out that there's a third person, the translator, in the consult. Doctors cut out the patient and develop a separate conversation with the translator. This includes not maintaining eye contact with the patient and so on. Doctors ask patients to undress, at which point the doctor either pulls a curtain and cuts out the translator or just expects the patient to undress in front of the translator, who is essentially a complete stranger. Doctors expect the patient to bring a family member to translate and are put out when the patient expects the medical facility to find one. Doctors don't ask whether the patients needing continuing care will be provided with the same translator, if the translator and the patient will have a continuing relationship. Doctors fail to understand that deaf patients are less likely to come to checkups and routine procedures due to language barriers. Doctors rate their interactions with patients very highly, though there has been no feedback from the patient. So, Here is some information about these communities from the BMJ. I am reading box 1, where it refers to terminology, identity, and language around hearing loss. The term capital D or lowercase deaf is used throughout this article. Capital D deaf refers to patients who primarily use sign language and identify with deaf culture and the deaf community. For our purposes at Twig, where we are translating signed languages, this is primarily who we deal with. Whereas deaf, lowercase deaf, refers to those who primarily use spoken English or their native spoken language. Patients in either group may use hearing aids or cochlear implants. The term hard of hearing is used by a wide range of patients. Okay. So above here it says in the UK around 1 in 7 people have hearing loss, rising to 1 in 2 of those aged over 70 years. So data from the World Health Organization indicates that in 2018, 466 million people, 6.1% of the world's population, had hearing loss, a figure expected to rise to 630 million by 2030. So it is important to note that patients have a variable presentation ranging from mild difficulties understanding speech in noisy environments to little or no speech recognition. In England and Wales, an estimated 900,000 people are severely or profoundly deaf, of whom approximately 70,000 use British Sign Language as their first language. The World Federation for the Deaf estimates that globally there are 72 million deaf people using more than 300 different signed languages, of whom more than 80% of these individuals live in developing countries. I think that all of this information is important, so I've read it out. I'm moving on now. Right. Over 5% of the world's population, or 430 million people, require rehabilitation to address their disabling hearing loss. So it says here, disabling hearing loss refers to a hearing loss greater than 35 decibels. So let's look at what that means in practice. Before we look at decibels, let's consider signed languages. So, how many signed languages are there in the world? Some sources report 200, some sources report as many as 300. Here is an estimate of the number of signed languages here are the top ones by number of speakers. So you can see Indo-Pakistani and so on by the number of speakers, ranked by the number of speakers. I note here that there's a family of origin, right? We can see family of origin, Nepalese Sign Language, French. Brazilian Sign Language is a language isolate, meaning it's the only one. So if you're asking yourself, can people who use signed languages be understood among each other? The answer is often no, most often no. Let's move forward. Here's our degrees of hearing loss. So here's decibel levels. Yep. We can see mild, moderate, severe, and profound. And you can see here the level of noise from whisper, inside average house, conversational speech, busy street, loud shout, all the way up to jet aircraft, right? So some people might know they have hearing loss, underestimate the amount of hearing loss they have, may use a cochlear implant, may not, may be embarrassed, may not. And here we're squarely in clinical communications and how to improve those. Picking up visual cues of a spoken message. It involves not only focusing on the lips, but the rest of the face. Lip reading is not exact. A lip reader will typically understand 30 to 40% of a conversation. The rest is guessing. Lip reading is hard work and tiring. Many words look the same on the lips, like bat, pat, and mat, whereas other words produce no lip pattern at all. Without clues from the topic of conversation, residual hearing, and the cooperation of the speaker, the deaf person may understand little of what is being said to them, increasing the chances of misunderstanding. It's also important to note that language barriers deeply affect people's lives and clinical histories. Here we have speakers of ASL, American Sign Language. And here we can see that 98% of deaf people do not receive education in sign language. 72% of families do not sign with their deaf children. 70% of deaf people don't work or are underemployed. 1 in 4 deaf people has left a job due to discrimination. And 1 in 4 deaf women will be sexually assaulted in their lifetimes, compared to 1 in 10 hearing women. Also a note about deaf interpreters. So legal interpreters and medical interpreters are high-stakes interpreters. They interpret in high-stakes situations. So the first bit of this says that the lived experience and knowledge of DIs are particularly important when interpreting in high-stakes situations where word choice and context can make a difference in outcomes, such as legal settings or certification tests. I would add medical translation. We move to the bottom here and it says very few certified deaf interpreters work in the field due to multiple barriers to certification. These barriers include fewer training programs, flaws in the certification process, bias towards English proficiency, the emerging nature of the deaf interpreting profession, and lack of job opportunities. I always find these stories very disappointing because the deaf community is guaranteed medical translation by law under disability law, and as such, and also has a long history of it, probably 2 decades plus now. So if this is the situation for deaf interpreters, medical interpreting will fall, in general, will fall even further behind. Yeah. Okay. If you are a user of any of the world's 200 to 300 sign languages, or if you're listening to me now, if you know a user of any of the world's 200 to 300 sign languages, please ask them to join Twig. The same applies if you are an advocate for speakers of signed languages. And here's our email and website right there, as always. Case study 4. So you can imagine that this case study involves deaf patients. So I'm going to go ahead and ask you to pause and read it. And I will move on. Okay, what do human translators do? Lessons from the deaf and hard of hearing translation communities. It is important to remember that we often do not know what medical translators do because doctor and patient communications are private. Again, we have no transcript. This is not the case, for example, with court or legal translators, as we've just reviewed. So, medical translation is ephemeral. Once an interaction is over, there's very little opportunity to go back and check for errors. Luckily, there is a wealth of research from signed language translators. So, here we have some service models for human translators. As we've discussed, the conduit machine model, 2, the communication facilitator model, 3, the bilingual and bicultural mediator model, and 4, the helper model. These are models that exist. We will just be looking at the conduit machine model for the moment. So, the conduit machine model. Many researchers have put great emphasis on the necessity of interpreters to transfer information neutrally without editorializing information. Several physician researchers have continued to categorize any discrepancies between the original and interpreted texts as errors, even today. So, The interpreter as conduit model minimizes the complexity of the interpreting process. So it is worth reflecting on whether you agree with this interpretation of interpreting or not. Homework assignment 6. Find someone who is bilingual and ask them to translate the following sentences. If you don't know a bilingual person, imagine why a translator might find the following sentences tricky to translate. Do you have any allergies? Are you sexually active? Do you take any over-the-counter medication? Have you had a dicky tummy, or have you had an upset tummy? These are examples where the conduit model isn't so useful because an effective word-for-word translation is unlikely in a second language. English is the problem here. We expect English speakers to know what we mean, but a translator will likely know that allergies can include a large range of symptoms. Sexually active can include a large range of activities. Over-the-counter medication could mean anything. Here in the last example, we have the same problem as allergies. Upset tummy may be a tummy problem, but it may be a delicate way of something more unpleasant. Researchers have discovered 3 techniques that translators use to better convey information: contextualization, contrasting, specification. Contextualization. Contextualization adds specificity to a language. The original question may be, do you take any over-the-counter medication, but is translated as, do you take any medication such as aspirin or supplements that you might buy at a place like Superdrug? Here's another example of contextualization. Here's another example of contextualization that, with a question like this, can get very complicated. Contrasting. By creating contrast, participants bring focus to the topic. The original question is, do you take any over-the-counter medication? And it might be translated as, do you take any medication that has not been prescribed by a doctor? Specification. This technique is often used to express the type and manner of a concept. So, in English, to take medicine is broad, but in American Sign Language, you can specify how you take medication, using a spoon, a cup, or just directly a pill, and also the quantity. So, the original question might be, do you take any medication? But it would have to be translated as, do you take pills or liquid from a spoon? Twig offers rephrase, which is a way of translators to offer contextualization, specification, and/or contrasting when a direct translation, word for word, is not possible in the target language. Latin words. Translators might change words deriving from Latin to something more understandable in the local language. Here we have some examples. Words imported from other languages. Some words have been imported from other languages. While it's technically correct to use them, the person you're speaking to might not fully understand. Some examples are glaucoma and heart attack. From psychology, there are even more examples. Coping, grooming, and stalking have been imported into other languages recently, but may not be clear to the person you're speaking to. Homework assignment 6B. Do you ever change your communication style for vulnerable patients who speak your same language? How do you change your communication style for children? Are you aware of any plain English campaigns in your field? Examples are in pharmaceutical packaging and public health campaigns. Did you receive training in altering communication for vulnerable patients as a part of clinical communications, or have you taught yourself? Could you use any of the techniques just outlined as part of regular patient communication? Case study 5. Yes, so this is, well, I'll let you read it, but this is a case regarding a Roma woman who did not understand a Latin term, and she had what we call a negative patient outcome. Yeah? I'll let you pause it and read it. Here's the judgment by the United Nations Committee on the case. Okay, medical translation in deaf and HOH communities, best practice. So, here's what we've learned from deaf and HOH communities. I'm going to skip this slide because we've talked quite a bit about this. Please do pause if you need to read the list fully. Okay. So, what exactly do human translators do? Speaking speed. When people think of translators, they often think of the trials at Nuremberg. This event is a milestone for professional translators, or should I say interpreters. Those giving evidence were told to speak very slowly, at 60 words per minute, the rate at which the translators translated. Examples of speech, words per minute. So, 60 words per minute, Nuremberg translators. That's 1 word per second. It's very slow. Here you can see some other speeds. The ideal speed for children is 124 words per minute. Yes. That's probably the speed that you talk to a 4 or a 5-year-old. Although it is possible on YouTube to find examples. I've given a link here of someone speaking at 124 words per minute. Many translators perfect their speaking speed. You may find that if no translator is available, you can try slowing your speech down. This works especially well when coupled with doodles and drawings. Note, seeming patronizing or condescending to patients is to be avoided, as is increasing the volume of your speech. And pauses. Do you interpret them as a sign of positivity, negativity, understanding, misunderstanding, agreement, disagreement? This differs from culture to culture. Here's some additional reading into these concepts if you'd like to follow up. And here we are at, can't computers do translation? There are many computer translation services, the most popular of which is Google Translate. Twig does not take a position on what translation options medical providers should use, including computer translation. Google Translate currently offers translation for 109 languages. Does computer translation work for medical translation? Well, to find out, you could try the completely unscientific, or maybe somewhat unscientific, method of translating a sentence into another language and then translating it back into English again. Here I've translated, he gave me a coffee cup, and it's come back, he gave me a cup of coffee. So when I sent the translation, I had a cup with no coffee in it, and when I got the translation back, I had a cup and coffee as well. You could also have a human translator check the computer translation. Here we have an original English text, a computer-generated Spanish translation, and an explanation of the errors. Here we have a study that says that 66% of computer translations were deemed incomprehensible. I'm looking at the results section. It says Results were classified into 3 categories: incorrect, concept conveyed but with linguistic errors, and correct. Out of 13 languages, 66% of translations were found to be incorrect, incomprehensible or not conveying the intended meaning, while 26% contained the correct concept but with grammar and syntax issues, and only 8% of translations were deemed to be of a high enough quality to use as is. There's the link for the study there if you'd like to take a look. This has to be my favorite, hands down. Another study showed that the accuracy depended on which language and question was being translated. And here we have the phrase translated and the sample most common error. Yeah. I also like the percentage correct. That's amazing. So, phrase translated, your wife is stable, becomes, your wife cannot fall over. Your husband had a cardiac arrest, translates to, your husband's heart was imprisoned. Your husband had a heart attack, translated to, your husband's heart was attacked. Your wife needs to be ventilated, translated to, your wife needs to be aired. Your child's condition is life-threatening, translates to, your child's state is not life-stopping. Your child has been fitting, translates to, your child has been constructing. Your child will be born premature, translated to, your child is sleeping early. Your husband has the opportunity to donate his organs, translates to, your husband is now ready to donate. We will need your consent for operation, comes to, we need your consent for operating, as in operating machinery. Did he have a high fever at home, translated to, your home temperature was high. So, the results are that Portuguese scored with 90% accuracy, Eastern European languages scored with 62% accuracy, and Swahili scored with 10% accuracy. So I like this study because it's divided up the languages as well. NHS doctors have been advised against using Google Translate in the United Kingdom. We can see that caution at left, but this is actually my clinic to the right, and they definitely use Google Translate. Tips for using computer translation systems, as suggested by our translators. Use short sentences. Avoid acronyms like COPD, EKG, MRI, and so on. Avoid Latin expressions. Use plain language. Remember that words for pain are often not translatable. Stabbing pain or burning pain might result in a literal translation of someone being stabbed or burned. Consider not using words that can have multiple meanings. So, to make up can mean to compensate, to be composed of, to invent, or to be happy. So we saw this example in the previous slides, where fitting, operating, stable, these words have multiple meanings in English, and that's how they were translated by the computer. Fine. So, note that in English we can describe a single concept with multiple words. So, this can be the case with verbs, adjectives, or nouns. Computers may have difficulty with this. So, verbs. To work out, as in to come to a conclusion, 2 words, 1 concept. To turn up, as in to present yourself or to be present, 2 words, 1 concept. So here in English we can divide them. This is not always easy for a computer to do, to reunite them and figure out the meaning, especially from multiple meanings. In English we can describe a single concept with multiple words. So here are some examples with adjectives and nouns. catheter-related infection rate, long-term radiation risk, 3 centimeter lateral laceration, and so on. Note that if we have an example, or any of these examples really, but let's take high-power ultrasound waves. I know, because I'm an English speaker, that high power is 2 words, but it's one description, it's one adjective. And I know that ultrasound waves are 2 words, but one noun, one thing. So here I have one adjective, one noun, but 4 words. This is not so easy for a computer to do, quite often. So here's some additional reading. Fine. Okay, so we have arrived at LEP physicians, limited English proficiency physicians. So we have a quote by Benedict Anderson who said, "The determinative fact about Latin was that it was a language of bilinguals. Relatively few were born to speak it, and even fewer, one imagines, dreamed in it." So the reason I mention this previous quote is because I often wonder whether English is just going to be a language for people who are not mother tongue. It is perfectly possible to have a medical consult in which both people are LEPs, limited English proficiency, doctor and patient. At this point, English is just a lingua franca for communicating. Much more research is necessary on this topic. Scholarship often talks about limited English proficiency patients. We don't love this terminology because it seems to assume that the patient would perfectly understand medical terminology in their native language, which is not the case, and the physician is a native English speaker, another thing we cannot assume. It's worth noting that native patients can also have negative views of medical professionals that they assume either don't speak English or aren't trained properly. This can involve a patient conflating ethnicity, nationality, language, race, citizenship, and culture. The BBC has recently reported that the NHS is, quote, riddled with racism. The General Medical Council did a study and found that the media in the UK commonly focused on NHS stories that fell into one of 4 categories. This, in turn, may have affected the types of complaints the GMC received. So, in the media, when we hear about doctors, we often hear about criminal doctors, foreign doctors, maverick doctors, and the patient victim's perception of doctors. So this is what you will probably hear about in the UK. So here is the perception that many patients have of foreign doctors from the media. So quite often in the last few years, we have heard about the case of Daniel Ubani, whose care of a patient led to a fatality. We will read about him in the next few slides. Here is what was said of the media coverage. You may want to pause this and read it. And here's the case study regarding Dr. Ubani and the fatality that occurred when he was treating a patient. Here's another case of a doctor called Alessandro Teppa, who also did not pass his English exams in the UK. Fine. Here we have the myth of the single word mistake. So quite often when we read through cases or newspaper articles, we hear that there's a translation error that just pivots on one single word mistake. Here are some examples from politics, of single word mistakes. In the first example, the single word is Berliner, because Berliner can be a donut or a person from Berlin. In the second example, the Khrushchev example, we will bury you. Russian speakers have variously translated it there's multiple options here. If you're interested in reading it, you can. But you can only imagine how difficult medical translation is. So these single word mistake myths are often appealing because, number one, in medical contexts, we often don't have full transcripts to show how good or bad translations are of an entire conversation. And I suspect that single word errors are more likely to lead to successful malpractice cases. However, these cases are the exception, not the rule. In our experience, bad translations don't come down to a single mistake. Errors in medical translation typically come down to multiple errors. What follows is probably the most famous single word error in medical translation history. And I'll let you read the translation here. There was a book written about Willie Ramirez. You can see the link below. But I was reading through the comments, and here it is. Here's the comment that struck me. This comment was left by a Spanish medical interpreter, and the thing that strikes me is the date. So Willie Ramirez, that case happened in 1980. This review was left in 2015, which makes one wonder how much progress has really been made in 35 years on this topic. Moving on. Safeguarding. Safeguarding is a massive subject for medical professionals, too vast for us to cover here in full. Two main points we'd like to cover are, number one, abusers who know the patient may attend consults as their, quote, translators. So think about cases of child abuse, domestic abuse, carer abuse, and human trafficking. Two, it may seem convenient to use minor-aged children as translators, again, air quotes, translators, either for themselves or a family member, but this is to be avoided at all costs. So, and here's a quote. Every country knows about specific cases where things went very wrong because of language barriers. An example often reported is that of a young woman who is accompanied by a male family member who does the interpreting and forces her to have an abortion. Most examples we know are not that extreme, but they all have in common that language barriers hamper good access to health care. Here's some efforts towards legislation on this front in California. Feel free to read it if you'd like to. It is tragic. In fact, I can see here a case where a 12-year-old boy was used to tell his Vietnamese mother she had cervical cancer. Case study 8. While every case is tragic, this case is particularly tragic. So here's the case of Victoria Climbié. Feel free to pause and read. Errors in the Victoria Climbié case, which I will read out. Sometimes Victoria went to hospital, and the hospital staff did ask for a French translator, but none was provided. Victoria's doctor tried using her own French to speak to Victoria's aunt, who in this case was her abuser. This doctor did not speak to Victoria directly or privately. The doctor diagnosed the injuries visible on Victoria's skin, which in reality were cigarette burns and lacerations, as scabies, quote, as insect bites could have originated from her African homeland of the Ivory Coast. Victoria had left the Ivory Coast over a year before, a fact Victoria's doctor presumably never found out. A police officer charged with Victoria's protection then refused to enter Victoria's house because she had a fear of catching scabies. The only person that helped Victoria in this situation was her French teacher. So this was the only translator she was ever provided. I mean, translator, ad hoc translator, informal translator, but certainly not a medical translator. When the case went to court, here is the doctor's testimony. It is a very depressing read, but I feel possibly pretty typical in some scenarios. Worth reading, please pause. All right, that's the end of safeguarding, and that closes out this presentation. If you go to twigcare.org, you can get the most updated version of the PDF of this presentation. And in the PDF, there's some appendices. So just to walk you through them really quickly. Appendix A, Patient Characteristics. Appendix B, Communicating with Children. Appendix C, Not Using Children as Translators. Appendix D, Translating Pharmaceutical Leaflets and Clinical Trials. Appendix E, Translator Quality. Appendix F, Printable Twig Posters. So we've created 2 images, and basically we're hoping that you'll just go to a normal printer, print one of these off, and then put it maybe in your back office, coffee area, corkboard. If you're a student, maybe your dorm or your clinical communications department, and just let other medical professionals and students know about Twig. If that's too old school for you, if that's not how you roll, this is also eminently shareable on social media. Just screenshot it and share it that way. So it's really important that wikis build communities. Our community is special, and we need all the voices that we can get. Every voice counts. If you see yourself in the patients that we've looked at here, the case studies, if you see your clinic in some of these practices, if you're interested in some of the discussions that we've had here and the topics that we've looked at, please, please, please come be a part of our community. We would love to have you. Otherwise, I'd like to thank everybody all the way down, every medical professional that's listened to this. I know that you are super, super squeezed for time, and I thank you.